Perfect. Okay, well, welcome everyone. Thank you all so much for joining. Welcome to our second webinar of the series and first of 2021. My name is Connor Handy from the Business Operations team at Shankle Clinic, and I will be facilitating this evening's presentation by Dr. Shankle, as well as the following Q&A session that we'll have. So before we jump in, I just want to review a few housekeeping items. Our session will start with a presentation from Dr. Shankle, what you all signed up to see here tonight, and then we'll open things up to some Q&A. Some of you have already submitted questions, which is great. Thank you for doing that. If you have questions that come up during the presentation that you would like Dr. Shankle to address, just please use the Q&A feature in Zoom. There should be a button at the bottom of your screen. And so those will come directly to me, and I will relay those to Dr. Shankle during the Q&A session. Just keep in mind that we might not be able to get to all of your questions, but we'll try our best within the hour or a little bit more that we have allocated. Lastly, this is being recorded now, and it will be posted to our website and our YouTube channel later on, either this week or early next week, so that you can rewatch or pass it along to other people who weren't able to attend tonight. And then I guess just one thing to mention is that you are not visible right now, as you probably have noticed, and we cannot hear you. So if you have questions for us, do type them in the box, and that's what we will address in our Q&A. Okay, so that's all the nitty-gritty stuff. Most of you know tonight's speaker personally, but for those of you who don't, I'll provide a brief summary of his many qualifications. Dr. Shankle is one of the country's leading experts on Alzheimer's and other age-related neurodegenerative conditions. He spent over 3 decades treating patients fighting these diseases, conducting research to advance our knowledge of the brain, and developing new treatments to delay or prevent the progression of cognitive impairment. In 1997, Dr. Shankle founded Shankle Clinic, a neurology practice headquartered in Newport Beach, California, focused on the management and treatment of neurodegenerative conditions. Prior to founding the Shankle Clinic, Dr. Shankle served as the clinical director for the Alzheimer's Research Center at UC Irvine, which he co-founded. He also served as the director of Memory and Cognitive Disorders Program at Hoag Neurosciences Institute. Currently, in addition to leading the Shankle Clinic, Dr. Shankle serves as the Chief Medical Officer at MBIC Corporation, and he's a medical director for the Orange County Vital Brain Aging Program. Tonight, Dr. Shankle is here to share his advice for improving memory and preventing dementia. We're all excited to hear from him on these topics. So without further ado, I will turn things over to you, Dr. Shankle.
There we are. Okay. Thanks for joining me. And I'd like to share with you some insights that I've gained as a result of actually using antibodies to treat different brain conditions that are so-called incurable. And I've learned that that's not necessarily the case by understanding the fundamental underlying cause of what are called degenerative brain diseases. And in the process of using antibodies, I've learned that many of these conditions, you can actually see improvement or stabilization. And I've learned a lot about the science behind that. And that led to a different perspective on how to approach these problems. And that's what I'm going to talk to you about tonight. Here we go. Let's see if I can find it. There we are. Where'd it go? There we are. Okay. So the title is Preventing Brain Dysfunction Requires a Different Perspective. And just let me ask one thing. Connor, is the slide showing, or is it a bunch of different slides?
Right now, it's just a blank white screen. It's in presenter mode, but I'm just seeing a white screen. So maybe you need to click through.
Let's see. This happened before.
When you were going through the test, it was showing as it should.
Let's see. It's not working now. Let's try it again.
I was seeing your screen before you went into the presenter mode. Okay, so now I'm seeing Zoom. So I must have switched screens on you.
Okie dokie. Let's see if we can find it.
Thanks everyone for bearing with us here. Wouldn't be a perfect Zoom call without a little bit of technical difficulty.
Oh, let's try it now. Yay. Okay, it's working.
Oh, not quite on our end. Yeah, I'm still seeing your Zoom screen.
Oh gosh. How about now?
There we go.
Okay.
All good. Go ahead.
Technology loses. Here we go. So the mission is not impossible to prevent the loss of brain function. However, it does require, I think, a perspective about, first of all, how things change as we age, and then a perspective about how the brain and body work. What you see at the top is a series of stages from normal aging to subjective changes in memory and other abilities that you can still compensate for and still carry on all your usual affairs. At some point, when there is a disease present, then that subjective change in abilities becomes so significant that it does interfere with your ability to do things like keep track of appointments or remember to follow up on something at a certain time later on in the day. That's when it requires assistance from others. That's called mild cognitive impairment. And beyond that, we have the stages called dementia, which are a severity, not a diagnosis, as is mild cognitive impairment is a severity that is not a diagnosis. Many causes of all these things. And so how do we prevent going from the pale green arrow to the mild cognitive impairment arrow? Because that's when there is something going on that's interfering with our lives. And so I like to think about preventing brain dysfunction as opposed to preventing dementia or preventing cognitive impairment, because the brain does many functions and we want to preserve them all. And the key is to understand the idea that the brain and the body are a functional system that depend upon each other. They also influence each other. And so if one is to preserve function as we get older, we want to optimize the functional system of the brain and body. And to optimize that, we try and maintain normal functions of the cell, because that is a very fundamental unit of all organs and parts of the body. Now, cells function by making their parts out of proteins. And these proteins have to be folded in a certain way to function properly. And so there's an enormous amount of machinery in the cell that's involved with folding proteins. And not only is there an enormous amount of machinery to fold proteins, but then there's a quality control inspector to make sure that the laundry got folded properly. And if it didn't get folded properly, then it's not going to do its job. That protein is not going to work. And so there's a number of systems that are designed to prevent misfolding, and a number of systems that get rid of proteins that do misfold, because it turns out that one of the dominant hypotheses of the cause of all degenerative brain diseases is the excessive accumulation of misfolded proteins. And understanding that begs the question, okay, well, how do we prevent the excessive accumulation of misfolded proteins? And we'll get to that. The brain and body have built-in natural repair systems. And so they're always trying to compensate for any damage. And so when a misfolded protein occurs, there's a compensatory system that gets rid of them. But if the amount of misfolding exceeds the capacity of the brain and body to get rid of them, that's when we start to see decline in function. Now, there are many, many ways to reduce misfolded protein production, as well as many ways to remove those misfolded proteins that break through. And what this shows is a very busy slide, but the intent is to show that every part of your body has a relationship to the brain, and the brain has a relationship to every part of your body. We have our GI system, the gut, the liver, etc. That takes food in and creates the building blocks and the fuel for the brain-body system. And it operates over a time scale of minutes to hours. We have your kidneys. Now, they make sure to get rid of waste products. They balance the water load in your body and brain. They release hormones to stabilize the cell environment. And they function over minutes to days. We have the endocrine system, the hormone system. It releases hormones that regulate the brain-body system, and that operates over a time scale of hours to weeks. We have the lungs and the heart. Now, they deliver oxygen, glucose, hormones, ions, and nutrients to the brain-body system over seconds to minutes. And then we need paths of communication. Well, we have blood vessels that allow the blood, the oxygen, glucose, the hormones, the ions, the nutrients, and the building blocks to flow to the organs and the brain. And they operate over seconds to minutes. Finally, we have an immune system that defends against foreign invasion, like a COVID virus or some other infection. And that preserves the brain-body system's function over weeks to years. All this communicates to the brain, and then the brain feeds back to all these organs through a separate nervous system called autonomic nervous system, autonomous. It basically communicates to each organ in your body and coordinates the action of all the organs so that they are functioning together as a system. And that the brain and the nervous system operate over a time span of seconds to hours. So you can see that each part of your body and your brain, they work together, they depend upon each other, and they influence each other. So if we want to optimize function, it really boils down to maintaining good function of the body and the brain. If we look at the major causes of brain dysfunction, what you find out is that regardless of whether it's the, in a sense, the neurodegenerative diseases such as Alzheimer's, which accounts for about 45% of all causes of brain dysfunction, but also the diseases of the organs and blood vessels, which are chronic medical conditions. And these chronic medical conditions, they account for another 45% of all causes of brain dysfunction. So brain dysfunction can occur due to the parts or can occur due to primary brain conditions. And both of them are treatable because there's a common mechanism to both of them, and that is the production and excessive accumulation of misfolded proteins. Now, it's the brain, like I said, is compensatory. It tries to repair damage. Excuse me. It tries to repair damage. And this is shown in a study by Montine up in Seattle, Washington, where they took a managed care population and they randomly sampled people over 65 and annually checked their memory until the year they died. And when they died, they did a brain autopsy and they looked inside the brain and asked the basic question, how many different types of misfolded proteins were there in the brain? Well, in the first picture you see, what they did was they measured the accumulation of the misfolded proteins of AD or Alzheimer's, which is in blue. LBD is basically Parkinson's, and that's in a green. And then VBI is basically vascular blood flow, strokes, things like that. And you can see that for the 112 individuals who were normal the year they died, virtually all of them had some amount of misfolded proteins of these three different types in their brain. And yet they were able to function normally and they were cognitively normal. So just having these misfolded proteins in your brain doesn't produce dysfunction because our brain-body system can compensate. However, in the group of people who had symptoms, had cognitive impairment, had dementia, the year they died, the difference was they had 3 times as many misfolded proteins on the average. And so the amount of the misfolded proteins matters. And if we can keep that amount from crossing the threshold of symptoms, then we can have a disease like Alzheimer's, we can have a disease like Parkinson's, we can have vascular disease and still be functioning normally. And it takes about 30 to 50 years of accumulation of these misfolded proteins before it crosses the symptom stage, unless there's things that are accelerating the production of misfolded proteins. I had a very nice young gentleman yesterday who had developed Parkinson's disease at 29 years old. And he had 2 genes that accelerated misfolded protein production to produce symptoms at a much earlier age. This is a picture of the actual process by which cells produce proteins and then fold them. In the upper left-hand corner, what you see, I wonder if I can use the annotation. Let's see. Yeah, let's try that. Okay, so in this upper left-hand corner, we have the nucleus, and it makes proteins like this. Now, these proteins, they're not folded yet. They get kicked out of the nucleus into the cell proper, the so-called cytoplasm, the fluid of the cell, and they're not folded. They look like this. Now, under normal circumstances, there's a machinery that folds it properly. And then when it's folded properly, it will combine with other proteins to create a functional complex to do its job and get transported to the place that it belongs in the cell. Now, some percentage of the time, the folding process goes awry. And when that happens, what you see is a misfolded protein. And when that happens, it can either get recognized as misfolded, and then we have special machines in our cell, like this one here, that literally chew up the misfolded protein into its individual parts and recycle it for refolding. Now, sometimes these misfolded proteins, they get past these defense mechanisms and they start to aggregate together. And when they aggregate together, they take on very special properties that can damage cells, whether they're a nerve cell or a kidney cell, doesn't really matter. And so let's take a look at that. Let's see, there we go. All right, what you see here now is actually a misfolded protein that has escaped the cell's defense mechanisms. And when that happens, it's going to, these themselves are the individual misfolded proteins that bind to a core of amyloid. And when you get enough of these misfolded proteins that have bound, they will anchor to the cell membrane. And think of it as every part of the cell membrane has a job. It does something different. And when these misfolded proteins anchor, they literally punch holes into the cell membrane until the cell membrane can no longer do its job and the cell dies. And that is a fundamental mechanism of every degenerative brain disease. Now, we do have one additional defense mechanism, and that's your immune system. And in your immune system, we have antibodies that will recognize these misfolded proteins. And here is a bunch of antibodies that have bound to the misfolded protein. And what that does is it prevents it from anchoring to the cell membrane. And when that happens, there's a chaperone, just like when your daughter goes out on her first date. We like to have a chaperone go with her. At least I do. And the chaperone escorts this bound complex of antibodies and misfolded protein out of the cell and out of the brain. And literally, it ends up getting peed out. So this is the kind of the last line of defense. And I started using antibodies somewhat fortuitously about 20 or 30 years ago. In the process, I found some very unusual things, such as people with, this is back in the late, early 2000s. And in the process, I found people who had Alzheimer's who would stop progressing and then were progressing 2 to 7 times more slowly than the average, and then they were previously progressing. And I even had 5 patients with Lewy body disease, a very different but awful disease, that stopped progressing entirely for years. And it was very exciting, but it was also kind of depressing because the cost of administering these antibodies intravenously is extremely high. So I looked for ways to bring the cost down. And what I found was that these antibodies could be inhaled through the nose. And I was able to get treatment effects that were bigger than when we injected them through the blood vessels, and was able to use doses that were 30 times lower, which enormously reduced the cost of the treatment. So that over the past 6 years, I've only used the antibodies by having them inhaled through the nose, and have treated 11 different degenerative brain diseases, all of which have no known treatment. And more than half of the 100 patients have shown objective and observable improvement for every one of these diseases. Not everybody gets better. Some people just stabilize. Some people, continue to get worse. But more than half either stabilize or do show signs of improvement, which is very exciting for diseases that are so-called incurable. And so I was using this mechanism that involves the use of antibodies that bind to the misfolded protein, and then with the right chaperone are escorted outside the cell and outside the body. So, I hope I've convinced you that misfolded proteins are an important part of preventing or getting rid of misfolded proteins, or preventing them from accumulating in the first place, are an important part of preventing brain dysfunction, or if there is brain dysfunction, to slow it down, stop it, or partly reverse it. And so one can ask, well, what kinds of things increase or decrease the misfolded proteins? The short answer is that all of the conditions you see that have a yellow border around them are very common conditions that, if they are not well managed, they all increase misfolded protein production. And this includes every chronic disease that's been studied: blood pressure, heart, stroke, diabetes, sleep apnea, reduced oxygen from other types of lung problems, obesity, high LDL or low HDL cholesterol, high fat diets, poor sleep quality, general anesthesia, depression, chronic stress, etc. Estrogen deficiency after menopause, if that's not corrected within 5 years after menopause, then there's an increase in misfolded protein production. And it doubles the risk of developing a dementia if estrogen is not replaced within 5 years of menopause. Head trauma also produces misfolded proteins. There's always genetics. Not much we can do about the genetics, but there's a lot we can do about these other conditions. And so the bottom line here is that treating existing medical conditions and managing them as well as possible is a very effective way at preventing or minimizing brain dysfunction. There's also lifestyle factors, cognitive exercise, physical exercise, and modest use of alcohol. A glass of alcohol, either wine or spirits, once a day in midlife actually reduces risk of developing dementia, and even up to 2 glasses a day does. By 70 years old, that drops to about 1 glass a day, but it's still not harmful and looks to be somewhat beneficial. There's reasons for that from a biological perspective, but as long as it's used in moderation, there is nothing per se that is dangerous about alcohol, unless one has a tendency to overuse it. Then it becomes a problem. It turns out that cancer chemotherapy, as a side effect, it reduces the production of amyloid misfolded proteins. And it turns out that persons with colon cancer and breast cancer have been studied in terms of the risk of developing Alzheimer's and other causes of dementia. And they have actually a lower risk of developing those, cognitive impairment and dementia than the general population if they have received cancer chemotherapy. Okay. Now, just to give you a couple of examples, this comes from the Orange County Vital Brain Aging Program. And what you see here are individuals, each of these colored bars, pairs of bars, is a different individual with a different condition. And the lighter color is the basically a measure of their memory performance, the MCI screen. And the lighter bar indicated there was a problem at that time. And they were advised to go back to their primary care physician and see if they had any medical conditions that needed to be better managed. They came back a year later. All of them had better managed one of their medical conditions. They all showed a 10 to 20% improvement in memory. And these include conditions like lupus, high blood pressure, hypothyroidism, atrial fibrillation, fatigue, depression, stress, obesity, and physical inactivity. So managing medical conditions better improves cognition. And to go back to that complicated slide, which has a very simple point, and that simple point is that the brain and the body work together, and that maintaining your health and maintaining good control of existing medical conditions is an effective way of minimizing brain dysfunction. And then if one combines that with an understanding that the basis for all of this is that when things are not well controlled, it leads to an increase in misfolded protein production, which ultimately leads to damage to cells like nerve cells, and ultimately leads to brain dysfunction. So with that, I will end and be happy to address any questions that people may have.
Okay, awesome. So I will facilitate some of this Q&A here. So I'm just navigating over to my list of questions here. The first one, was about alcohol consumption. I think you did a good job of touching on that, Dr. Shankle, and that alcohol consumption is not only is it not detrimental to your mental health, but can be somewhat beneficial depending on your age in reducing the risk of dementia. I think just something to note, we've had patients ask specific questions about alcohol consumption with the medication that they're on. So I think it's just important to, as a general, overall to just note that you should consult either Dr. Shankle or your primary care physician about the different medications that you are taking or that your loved one is taking, and whether there are risks of consuming alcohol with those medications. So just a general note there. We did have, so a lot of these questions, general theme are on things that can be done, and one question was about a keto diet. So someone asked, does a keto diet help prevent dementia? So I don't know if you know specifically about the keto diet. It sounds like there are certainly advantages of regulating your diet and avoiding obesity, but do you know anything specifically about the keto diet?
Yes, when there's the primary fuel of cells is glucose, sugar, and the hormonal system regulates the delivery of glucose to all cells of the body and brain. In the absence of glucose, then it triggers generation of an alternative fuel, which is ketones. This is the so-called concept behind the ketotic diet, or the keto diet. And there are certainly useful situations where a keto diet is helpful for a medical condition. It has been looked at as a general solution for dementia, for Alzheimer's. And at best, what they found was that it was helpful in improving symptoms for about 9 months. And after that, it was difficult to demonstrate a beneficial effect. So I would say that for specific medical conditions, the keto diet can be very helpful, but as a general approach to treating or trying to improve outcomes in cognitive impairment and brain dysfunction, it hasn't demonstrated to be as valuable as some people thought.
Okay, great. Thank you for that. So along the same lines of kind of regular behaviors, someone asked a question about sleep. So obviously, you mentioned, I think, the importance of getting adequate sleep. If someone is, not getting a full night's sleep, so say getting 5 hours as opposed to the recommended 7 to 9 hours, someone was curious if a nap during the day would be beneficial in kind of contributing to the overall amount of sleep that you're getting?
It's a good question, and let me rephrase the question. What is the purpose of sleep? The purpose of sleep depends upon the stage of sleep you're in, and there's basically two fundamental stages. There's the initial stage where you fall asleep. And during that, what is going on, this is called slow wave sleep, where the brain waves slow down enormously. And it's called restorative in the sense that many of the waste products, such as the misfolded proteins that get taken out by antibodies, many of those waste products are excreted from the brain during this slow wave sleep. There's a second part of sleep called Rem, Rapid Eye Movement, and where our body is paralyzed except for our breathing muscles and our eye movements. And that is the classically associated with dreaming. But it turns out also that it's associated with consolidating the memories that you had during the day. So each stage of sleep has a different purpose. And if a person sleeps but doesn't go through those stages, then, for example, if the slow wave sleep is shortened, you get a buildup of these waste products, many of which are misfolded proteins, which increases the risk for brain dysfunction and a degenerative brain disease. And if a person doesn't go through REM stage sleep, they don't consolidate the memories of the day as well, and they will perceive that there's a memory problem. So the real issue is if you take the combination of the 5 hours sleep and a nap, does that give you adequate amounts of each of those stages? I don't know the answer to that. However, many times the reasons for a nap is that there is some impairment of sleep quality, such as a sleep apnea, such as restless legs or restless arms, or talking in your sleep, or having nightmares or terrible dreams, things that are associated with an impairment of or a disruption of the stages of sleep. And in those cases, it is best to find the underlying cause and to treat it, to restore those stages of sleep so that you get about 7 to 8 hours total. And these stages, they cycle through the night, so that about every 45 minutes, we go into a REM stage where we're consolidating our memory. And then we go back to the slow wave where we're getting rid of waste products. So I think the important message here is that sleep quality involves feeling rested when you wake up, and it involves going through both stages in enough time to be able to consolidate memory and get rid of the waste products of the brain.
Great, thank you. How about exercise? So can you speak to the importance of regular exercise? And we had someone ask whether there are certain types of exercise that may be more beneficial than others in preventing dementia.
Exercise is fundamental. It's if you think about it, if a drug company could put physical exercise, could put an hour of physical exercise into a pill, it'd probably cost about $100 a pill. Physical exercise has so many beneficial effects in terms of the fundamental actions of cells, the use of glucose, the use of oxygen, the strength of the heart muscle to be able to pump blood to deliver the nutrients to the different organs is dependent upon physical exercise. They've also found that so-called resistance exercise, where you build up muscle tone and muscle bulk, also is useful, and that a combination of cardiovascular and resistance exercise is associated with overall better health and overall reduced risk of brain dysfunction. The recommendation based on the research is that if you do 45 minutes, 4 days a week or more, to the point of getting either short of breath or sweaty, that constitutes a sufficient amount of physical exercise to actually show reduced risk of cognitive and brain functional decline.
Great, thank you. So in your slides, you mentioned cognitive exercise as one of the factors, the mitigating factors. Would remaining socially active fall in that category? Is that something that's also important?
Yeah, so social, if you think about what is socially active is interacting with other people. And when interacting with other people, one is using language, describing situations, recalling events. One's also listening and trying to comprehend what someone else is saying. There's quite a bit of engagement of different brain areas with socially active individuals. There's also multiple levels of listening, where you're listening for the content, but you also may be listening for a hidden message. So it's quite a very high level cognitive activity, and is not something that's been as well researched as other types of lifestyle factors. But it's very clear from the research that's been done that it should be considered as a very good form of cognitive exercise.
Awesome, thank you. So we have a few questions about estrogen deficiency, specifically in the case of women that are 10 to 20 years post menopause. So I don't know if you have thoughts on an like estrogen supplement, or whether that is something that you would recommend.
Well, in men and women, we have sex hormones. The sex hormones, they initially, when we're born, the greater preponderance of testosterone in the male brain develops the right side of the brain, the nonverbal or visual side, more than women. And in women, the preponderance of estrogen develops the left side of the brain more than men. This is why we typically see men as being more visual and women as being more verbal. Now, one of the things that estrogen does is it maintains a growth factor in the brain, which is called nerve growth factor. Nerve growth factor does what it says. It helps nerves grow, particularly a group of nerves that release a brain transmitter called acetylcholine. And acetylcholine is involved in memory, executive function, vision, processing of vision. And when menopause occurs and there's a decrease in estrogen levels, one sees a decline in the levels of nerve growth factor and a decline in the levels of the brain transmitter, as well as a decline in, particularly in women, it'd be more verbal memory, okay? So by replacing estrogen, once it starts to decline, it helps bring the nerve growth factor levels back up. It helps preserve the nerve cells that release acetylcholine and helps preserve the functions that it does. And it turns out that in a variety of degenerative brain diseases, the population of nerve cells that are protected by nerve growth factor decline significantly. This is one reason that ribostigmine, or the Exelon patch, is effective in Parkinson's, Lewy body, Alzheimer's. There's a dramatic reduction in acetylcholine neurons. And women who do not replace estrogen within 5 years of menopause, they are about twice as likely to develop cognitive impairment compared to women who do replace with low-dose estrogen therapy. Claudia Cowis showed that in the Leisure World study of more than 20,000 individuals who were followed over 25 years of life, that women who engaged in estrogen replacement within 5 years of menopause were 15% more likely to live than women who did not. And the only increase in risk of estrogen replacement therapy was a 1% increase in the risk of a mini stroke or a stroke for 1 year. After 1 year, there was no increase in risk. The only caveat for estrogen replacement therapy would be in women who have estrogen-sensitive breast cancer or are at high risk for estrogen-sensitive breast cancer. That's different, and it requires a different approach. One thing that's kind of interesting that I learned about was that there is an alternative way to help increase nerve growth factor besides estrogen. And it turns out that a mushroom called lion's mane does in fact increase nerve growth factor. So when I have patients who can't take estrogen, then I have them take lion's mane, and I have a paragraph that gives the details on the dosing and the products and stuff. So there are other ways to maintain nerve growth factor, and there may be other functions of estrogen, but that's clearly one of them that is helpful in reducing the risk of decline in brain function as we age.
Yeah, I love lion's mane on pizza. Okay, so we're at 7:02. Do you have a couple more minutes, Dr. Shankle, to take a few more questions?
Yes.
Okay, great. So we had someone ask a question about is there a relationship for Alzheimer's or dementia to people who have been on antidepressants for an extended period? I don't know if you know that specifically.
Yeah. So again, I'm going to rephrase the question to fit the science. In persons who have depression, and this is chronic depression, for many years, it results in a reduction in brain activity in certain areas of the frontal and the temporal lobes if depression is not treated. What they find is that there is actual loss of brain tissue in untreated depression, and it happens to occur in areas involved in memory, the same areas that are first affected by Alzheimer's disease. And so untreated depression increases the risk for cognitive decline. That goes back to the idea of controlling existing medical conditions as well as possible. You have heard of, in long-term use of antidepressants, there may be an increased risk of suicide and other things. I really don't know a lot about that. In my clinical experience, I've never encountered that as an issue. Doesn't mean it isn't an issue. It's just that I've never actually experienced that in the patients that I've taken care of. And it's clear that not treating depression is a risk factor for cognitive decline, as is not treating a generalized anxiety disorder, as is a chronic stress or not addressing post-traumatic stress. All of these things, when you increase anxiety, stress, what does it do? It increases the release of a hormone from the adrenal glands called cortisol. And when cortisol levels go very high, they actually kill cells. And there's a classical MRI finding that's called granulovacuolar degeneration. And if you can say that 3 times, you never need to see me. I call it GVD. It's easier. Or little black holes in the hippocampus. it literally punches little black holes in the hippocampus. So it affects memory. So chronic high stress, if it happens to be an anxiety disorder, there are many treatment approaches to that. In post-traumatic stress disorder, there's a very well-established and simple treatment called eye movement desensitization reprocessing. It's biologically based, and 24 out of 25 double-blind studies have shown that it is an effective treatment for post-traumatic stress disorder after just 8 sessions. So the basic idea here is that the so-called psychiatric conditions, they have real biological consequences if untreated. And whether using the same antidepressant for one's entire life might be not such a good idea. Okay, that's something that can be addressed, but not treating these conditions is definitely a problem.
Great, thank you. So just last one before we head out here, we have several people who have asked questions about whether or how they go about determining whether they're candidates for certain antibody treatments. And specifically, we've had some questions about your trials and some of the investigations that you yourself are doing. So if you could speak a little bit to that and how people may best reach out, that would be great.
Okay. I want to be real clear that my experience with antibodies is certainly not not something that a lot of physicians have done. So it would not be fair to characterize it as well established. I would say that if you look at TV ads by pharmaceutical companies, almost every commercial you see for almost every medical condition, the name of the medication ends in MAB, M-A-B. That stands for monoclonal antibody. We are finding that the proper use of antibodies that target specific causes of disease is very effective. It's a general trend. It's not just brain diseases, it's diabetes, gastric conditions, cancer, you name it. Just look at, next time you see almost all the commercials on TV are either cars or drugs. And look at the name, the last 3 letters of almost every drug you see ends as MAB. That's an antibody. So what I'm doing is not really out of the realm of bizarre. All of the trials for Alzheimer's disease in the last 10 years, maybe longer than that, have used antibodies. The primary difference from those trials and what I'm doing is I'm not using an antibody against a single misfolded protein. I'm using antibodies that are derived from humans, blood donors, and they have antibodies against many misfolded proteins. And that may be why it's been successful in treating a wide variety of degenerative brain diseases. And also one reason why it may not be successful in all patients is that the amounts of those antibodies from human blood donors is only about 5% of the total antibody population that you get. And we're going to try to remedy this in the CHIPS trial by identifying which antibodies each person has in their blood that would bind to misfolded proteins in their brain. And if we are successful at doing that, we can then extract just those antibodies and give extremely small amounts of them by having them inhaled through the nose. And the potential is that it's approximately somewhere between 20 to 500 times more misfolded protein would be removed per milligram of antibody that's directly from the patient and directly targeting the brain, compared to what I can currently use, which is basically commercially available antibodies derived from populations of human blood donors. So I'm attempting to not be restrictive in the trial. I'm attempting to allow any degenerative brain disease to be in the trial, as long as we can demonstrate they have misfolded proteins in their brain. That requires spinal fluid. And I've worked to make that so that it does not hurt to get spinal fluid. What else can I say? I've also attempted to eliminate the narrowness of the trial. Most times FDA trials require that you have a certain range of severity and you can only have one disease, okay? And that is because it is hard to include a broad variety of people with different severities and different diseases and have an outcome measure that will work for all those conditions. Well, I put a lot of thought into that and come up with ways that we can do that. And because of that, we don't have to restrict it to any particular disease and any particular severity. So I'm hopeful that a large number of people who wish to be involved will be eligible.
Great. And I think that as we see it now, they will have to be in the Orange County area, or travel to have certain measurements taken, but I guess that's to be determined.
I think another aspect of the trial is really to try to minimize the effort needed to be in a trial, because most FDA trials require a lot of time. And so what we're going to try to do is use telemedicine as much as possible to minimize travel. And so if a person isn't in Orange County, but they're willing to come, I don't know how many times a year, maybe 4 times a year, that is definitely something we can consider.
Great. So yeah, I'm sure, we'll be disseminating more information about the CHIPS trial to patients as it becomes available and that becomes finalized. I think, it might be worth saying if you're not a patient of the Shankle Clinic at the moment, but would like to receive that information, certainly feel free to reach out to us and we can make sure you're on a list to receive that when it becomes available. We are at 7:15. Thank you for the many of you who have stuck on through the length of this. I know that we're a little over our allotted hour. Thank you, Dr. Shankle, for being willing to flex your time here. And I think we will wrap it at that. I know that there are several questions that we haven't had the chance to go to, so I will review those and circle back with Dr. Shankle, and we'll try to get responses to as many of you as we can. And once again, this will be posted to our website and our YouTube channel, so stay tuned for that link. And we'll be also with a quick poll with just a few questions that will help us plan future webinars. So thank you very much. Thank you, Dr. Shankle, and hope you all have a great night.
And thank you, Connor. You've been very, very helpful.
Appreciate it. Okay, talk to you all soon.
All right. Bye-bye.